The assessment that I'm going to be talking about today is the Pediatric Evaluation of Disability Inventory, also known as the PD. So this is a functional occupation-based assessment. It is also a performance measure. It is standardized for the pediatric population. The assessment is intended for children between the ages of 6 months and 7.5 years old. And then roughly it takes about 30 to 60 minutes. And this is kind of dependent upon how long the parent or the therapist takes to administer the assessment or just fill out the questionnaire. So the PD assesses 3 main areas, which are functional skills, level of independence, and then the need for modifications in terms of how a young child performs functional activities. So I'm going to go in a little bit of depth about each of these areas. So functional skills assesses the child's functional status and performance capability in self-care, mobility, and social functioning. The level of independence assesses the level of assistance that the caregiver provides during functional activities of self-care, mobility, and social functioning. And then the need for modifications assesses if the child makes their own modifications, if they use adaptive equipment, if there are any extensive modifications that have been made to their environment in order for them to complete functional activities. So some populations that are typically use the PD include cerebral palsy, traumatic brain injury or acquired brain injury, Down syndrome, autism spectrum disorder, and spina bifida. These are just some common diagnoses within children. Some other pediatric diagnoses that are a little bit less common, but the PD can still be used on, include Fragile X syndrome, juvenile rheumatoid arthritis, and other chromosomal anomalies. Research has suggested that the PD is more successfully used on children with severe disabilities rather than children with less severe disabilities such as ADHD, ADD, or some children with developmental delays. So in terms of administering the PD, it's broken up into 3 parts. And then there's also 3 domains across all of the parts. So the 3 domains are self-care, mobility, and social functioning. So within part 1, this addresses functional skills for all 3 of these domains. So there's 197 items, and this is typically performed by the parent independently. But another professional that knows the child well can also fill out this assessment. It's just whoever observes them on a regular basis. And then the image to the right is an in-depth overview of the areas that are covered in this section. And each of the domains has a different area of focus that pertains to the child's everyday activities. So as you can see, the self-care and mobility domains address ADL functioning, and then the social domain focuses on cognition, play, and IADLs. In terms of scoring for part 1, this is the easiest scoring of all 3 of the parts. It's just 0 or 1. So 0 meaning that the child is unable or limited in capability to perform the item in most situations. And a 1 means that the child is capable of performing the item in most situations, or that the item has been previously mastered and functional skills have progressed beyond that level. And so the image to the right is directly pulled from the PD, and this is for use of utensils. So the parent would read this and say finger feeds, and they would check off if their child is capable of doing that or not capable of doing that. In terms of administering part 2 and 3, so part 2 is based on the level of assistance that the caregiver gives. And then part 3 is based on the modifications that have been made to assist the child in completing everyday activities. So this is 20 items total, and ideally it's to be administered as a parent interview. So the therapist kind of prompts the questions, and based on the parent's responses, they dictate what score they get. And the image on the right here is another breakdown based off of the 3 domains. and just kind of an in-depth overview again. And it addresses some similar areas that the part 1 did as well. So as I was saying, for scoring for this, it's different than part 1. So this aligns to a 0 to 5 scale that are based on the levels of assistance. So the scores represent the level of help that the parent actually and routinely gives, regardless of what the child is able to do. So a 5 is independent, a 4 is supervision, 3 is minimal assistance, 2 is moderate assistance, and 1 maximal assistance, and then 0 is total assistance dependent. And so many parents don't understand the levels of assistance and the difference between them. And that's kind of why this section is an interview based, because the therapist knows the levels of assistance and is able to put the correct score for that. And then the image here on the bottom is directly pulled from the PD, and it's how the levels are presented on the questionnaire sheet. So if you look at eating here, the parent would determine based on how much they help, what level of assistance they would be. And then scoring for part 3 is different than part 1 and 2. So this is more of a letter score that indicates the type of modification that is used by the child to complete the specific everyday activity. So the letters are N, which equals no modifications. C is child-oriented. So that's kind of modifications that they've made on their own. R is rehabilitation equipment, which is things that OT or PT, this can be adaptive equipment, anything like that. And then E is extensive modifications. So this section does not typically contribute to the assessment scores, and its purpose is more for the healthcare professional who's administering the assessment to just gather valuable information about the child. The section can be counted if the child needs the equipment, but if not, the child prefers the equipment, it can do the skill without it. And then the image at the bottom, again, is pulled directly from the PD, and it kind of shows how this section appears on the questionnaire. So in terms of interpreting the PD, once all the items have been completed, the administrator will add up the scores for each domain and place the value in the raw score column on the score summary sheet, which is shown in the image here on the right. So for parts 1 and 2, they're scored the same way. So you just sum the values for each of the 3 domains, and that's evidenced on the actual score sheet. And so the max score that you can get for the functional skills section for each domain. So for the self-care domain, the highest a child could score is a 73. The max score for the mobility domain is 59. And then the max score for social functioning domain is a 65. And then for the caregiver assistance, the max score for the self-care domain is 40. The max score for the mobility domain is 35. And then the max score for social functioning domain is 25. And then in terms of part 3 for modifications, this is interpreted differently. So it's based on how frequent a component of the scale was chosen. So you would add up how many the none section, how many of those were checked off, and then how many of the child-oriented was checked off, and you total by column for each of the domains. And so it's more of looking at the frequency. And it's in this image, it's on the very bottom. And as you can see, there's a box for each of the letter answers for each of the domains. And so here's interpreting the PD continued. So once the raw scores are tallied up, you're going to compare to normative values. So there's only norm standard scores for parts 1 and 2, which is the functional skills and the caregiver assistance, and there's no norms for the modifications. So the raw scores can be configured into a normative standard score and a scaled score. And this image here is what the administrator would fill out to document the norm and the scale score, and overall show any outliers in the child's areas of need to improve. So this is like the key part of interpreting the PD, because this provides a measure of the child's overall performance relative to their peers. And this step is very relevant to clinicians, and it allows them to better understand the child's area of need and kind of where to focus their interventions based on if they are to score below the norm for their age group. And so these are just some examples of the normative values, and these are the charts that you would use. So the charts range from 5 months to 7 years old, and they're categorized by age range. And then there's 2 norm scores for each age range. So there's one standard score for part 1, which is the functional skills, and then there's one standard score for the caregiver assistance. And then the standard scores, the charts are all broken up based on the domain. So here on the left is the self-care domain norms, and then here on the right is the mobility domain norms. And then this is just the third domain of social functioning and the norms. But again, all the charts have the same columns, just the values are different. And then here's the link to my video of me administering the PD. It's a few minutes long, and I attached my slides and the link to this video in the discussion forum, so you can all access it there. So the minimal clinically important difference for the scores on the PD, there's limited research that's been conducted relating to this. And I was also unable to find research for the MDC value for this assessment, but I was able to find one article by Iyer, and this was completed in an inpatient rehab setting. And they basically found here, I took a direct quote from the article, that 11 points on a 0 to 100 scaled score metric was the minimal clinically important difference of the PD for the functional skills and the caregiver assistance skills. So essentially, this means that 11 points represents the smallest amount of change that might be considered important by the patient or the clinician, or something that the patient may feel from doing the intervention. To put that into more sense. This article did only have 53 children as the sample size. So that kind of means that more research needs to be done in order for this information to be more generalized and valid. So in terms of validity and reliability, overall, the PD has very strong psychometric foundation and has been proven to be a popular assessment tool in clinical practice. So that's kind of reflective in its validity and reliability. So it has excellent inter-rater and intra-rater reliability, which was supported in research that was conducted in both inpatient and outpatient settings, specifically with children with cerebral palsy and developmental delays. It also showed strong criterion validity, and that was established in multiple studies with children who had myelodysplasia, juvenile rheumatoid arthritis, and cerebral palsy with the pediatric population. And then there was also strong convergent and content validity, and those were kind of evidenced throughout research that I found from different articles. And then these are my references. Thank you for watching, and I hope that you were able to learn something new about the PD.